This recorded lecture will be going over Chapter 9, Drugs Affecting the Renal, Urinary, and Cardiovascular Systems in the Introduction to Clinical Pharmacology textbook. Interactions between the renal urinary system and the cardiovascular system can help to maintain fluid balance, the delivery of nutrients, and removal of any waste products from cells, tissues, and organs. Many of the drugs that affect one of these systems will also affect the functioning of the other. The renal urinary system controls blood volume in the body and the content of fluid portion of the blood because of its close connection with the cardiovascular system. A diuretic is a drug that decreases fluid volume by increasing urine output. Although the site of action is in the kidney, diuretics are chiefly used for cardiovascular problems, including high blood pressure and heart failure, rather than for kidney problems. Diuretics are typically classified into three groups: thiazide, thiazide-like diuretics, and loop diuretics, and potassium-sparing diuretics. Thiazide and thiazide-like diuretics will work at the end of the ascending loop of Henle and the beginning of the distal convoluted tubule in the nephron. They act to reduce blood volume. This class of drugs will increase urine output by preventing water, sodium, potassium, and chloride from being reabsorbed into the blood through the walls of the nephron. As a result, water and electrolytes will stay within the tubules, making their way through the renal system into the bladder and then being excreted through the body. Overall, they reduce blood volume. Thiazide and thiazide-like diuretics are the most commonly used type of diuretic and are often the first-line agents in the management of high blood pressure. A loop diuretic is a drug that increases urine output by blocking the active transport of chloride, sodium, and potassium in the thick ascending loop of Henle. Loop diuretics are widely considered the most powerful of the diuretics. Their use can result in a significant decrease in fluid volume and an increase in urine output. Potassium is one of the major electrolytes that can be lost after loop diuretic administration. We must monitor potassium levels carefully because significant changes in potassium will result in cardiac dysrhythmias. A potassium-sparing diuretic is a drug that increases the excretion of water and sodium, leading to increased urine output without the loss of potassium in the urine. These are called potassium-sparing drugs because they will not waste the potassium, which can often occur with thiazide and loop diuretics. Diuretics are typically used in conditions that will require a decrease in edema. Some common side effects of diuretics would include urinary urgency and frequency. Some other expected side effects would be dry mouth, increased thirst, and lightheadedness. Diuretics will increase urine output, and as a result of this, dehydration can be a major adverse side effect. Signs and symptoms of dehydration include increased heart rate, low blood pressure, decreased urine output or dark yellow urine, dry mouth with a sticky coating on the tongue, and tenting of the chest or forehead whenever pinching the skin. Thiazides and loop diuretics can cause severe hypokalemia, whereas potassium-sparing diuretics can cause hyperkalemia. A major adverse effect of all diuretics is severe low blood pressure that can result in falls, particularly in our high-risk older adult patients. Increased loss of potassium can result from use of thiazide or loop diuretics and if the patient is taking corticosteroids or certain antibiotics. Patients taking potassium-sparing diuretics should avoid any salt substitutes to decrease the risk of hyperkalemia. Assess your patient for changes in vital signs, particularly a decrease in blood pressure. If the patient's weight is below his or her normal weight, you should contact the healthcare provider before giving the diuretic. Check your patient's most recent potassium level. Give diuretics in the morning to avoid disturbing the patient's sleep at night. Make sure that patients know to ask for help whenever they are getting up. For thiazides and loop diuretics, teach the patient to eat foods that are high in potassium. For potassium-sparing diuretics, teach patients to avoid foods that are high in potassium. Patient and family teaching. Tell your patient and family the following. Take the drug exactly as prescribed. They should not skip or double any doses. Doses will be best taken early in the day to avoid affecting sleeping at night. If you're taking a thiazide or loop diuretic, you must include several high potassium foods in your diet every day. If you're taking a potassium sparing diuretic, you must avoid foods high in potassium and salt substitutes. Use sunscreen and protective clothing to avoid any skin irritation due to photosensitivity, and report any signs of abnormal potassium levels, including muscle cramping, weakness, numbness or tingling in the extremities, or a sensation of an irregular heartbeat. It is helpful to monitor daily weight. If you are taking a diuretic for your blood pressure, remember that high blood pressure is not going to be cured by drugs, and you should never stop taking the drug without consulting your healthcare provider. Avoid taking any over-the-counter drugs without discussing them first with your healthcare provider to avoid any drug interactions. Benign prostatic hyperplasia, or BPH, is a non-cancerous growth of the prostate gland. It is frequently seen as men age. When the prostate gland becomes large enough, the patient can have problems urinating because the prostate will put pressure on the bladder and urethra. Bladder anesthetics are drugs that when taken orally will be excreted into the urine and act as a local anesthetic on the mucous membranes of the urinary tract. The only drug in this class is phenoxyperidine or pyridium. It can control symptoms of urinary irritation, including burning, pain, and urinary frequency that often results from an acute urinary tract infection. You should warn patients that this drug will turn urine an orange-red color that can stain the toilet and their clothing. It's not an antibiotic and it cannot cure a urinary tract infection when used by itself. The person with an overactive bladder will feel a sudden urgent need to urinate and may lose bladder control before they reach the toilet. Drugs prescribed for OAB include urinary antispasmodics. These will improve symptoms and reduce incontinence by relaxing the bladder muscle. Two major risk factors for cardiovascular disease are levels of high blood lipids or hyperlipidemia and high blood pressure. Effective drug therapy can modify both of these risk factors. To treat angina, selected cardiovascular drugs can dilate the coronary arteries, delivering more blood and oxygen to the heart muscle. Over time, the ability of the heart to pump will decrease in patients with prolonged high blood pressure and/or changes in heart muscle resulting from an MI. This decreased ability of the heart to pump effectively is known as heart failure. Dysrhythmias can cause significant decreases in cardiac output and even death when not managed effectively. Several cardiovascular drugs will be used to restore normal heart rhythms. A patient may be taking drugs from a variety of cardiovascular categories. Anti-hyperlipidemics are drugs that treat hyperlipidemia, particularly by targeting blood cholesterol levels. The body does need a certain amount of cholesterol to make healthy cell membranes, hormones, vitamin D, and bile acids. It is also a normal and vital part of our blood plasma. Blood lipids will move through the body attached to protein carriers, known as lipoproteins. When considering cardiovascular disease and atherosclerosis, the most important lipoproteins are high-density lipoproteins, or HDLs. These are protective, and low-density lipoproteins, or LDLs, are harmful. So HDL is your good cholesterol, LDL is your bad cholesterol. HDLs will scavenge harmful lipids from the blood so that they don't stick to blood vessels and do not contribute to plaque. LDL cholesterols, on the other hand, are major contributors to the onset of and progression of heart disease and stroke. Most lipid-lowering drugs will tend to reduce LDL and other fatty acids. 4 classes of drugs are used to treat hyperlipidemia, including HMG-CoA reductase inhibitors, these are known as your statins, selective cholesterol absorption inhibitors, fibric acid derivatives, and bile acid sequestrants. HMG-CoA reductase inhibitors, or statins, are anti-hyperlipidemic drugs that lower blood LDL levels by slowing cholesterol production in the liver. They do not remove dietary cholesterol from the blood. The statins are the most effective drugs for lowering LDL levels and raising HDL levels. Statins are approved only to lower blood cholesterol levels. The most common side effects of statins are abdominal pain, headache, diarrhea, muscle pain, and joint discomfort. Liver failure has been reported rarely. With higher doses of statins, patients can experience rhabdomyolysis. This is muscle breakdown. This condition is very serious and it can be life-threatening. Signs and symptoms of rhabdomyolysis would include general muscle soreness, muscle pain, muscle weakness, stomach pain, and brown urine. Statins can be dangerous if used during pregnancy, and for the same reason, they are contraindicated in women who are breastfeeding. Alcohol and acetaminophen will increase liver toxicity effects of statins. Even though the patient is taking a drug to decrease their cholesterol, this is not a good reason to continue eating foods high in saturated fats, including fatty meats, fried foods, and baked goods, including trans fats. You should ask patients about their use of alcohol before starting any statin therapy. While on statin therapy, patients may have to have scheduled blood lipid levels drawn as ordered by their prescriber. These levels are typically measured 4 to 12 weeks after beginning the statin therapy and after any dosage changes to evaluate response to treatment. The timing of statin administration can impact patient response. Some statins will work best when given in the evening, but many can be taken once a day without any regard to meals, although some may need to be taken twice a day. Assess your patient for any jaundice and for darkening of the urine or clay-colored stools. These would be indicators of liver toxicity. Teach your patient and family the following. Lifestyle changes such as exercise, a low cholesterol diet, and good weight management are just as important as taking the statins in order to prevent cardiovascular disease. Make note of the recommended best time of the day to take your statin, and then try to take it at the same time every day. Inform your healthcare provider if you may be pregnant or plan to become pregnant, because statins can cause birth defects. Avoid grapefruit juice when you're taking statins. If you have any signs of liver problems, notify your healthcare provider immediately. If you have severe muscle aches, notify your healthcare provider immediately. Expected side effects would include headache, stomach, and mild achiness. These will typically get better within a few weeks after starting the statin. Non-statin anti-hyperlipidemic drugs. These drugs will be used less often because they are not as effective as statins. They would most likely be prescribed if the person is not responsive to or unable to tolerate statins. Selective cholesterol absorption inhibitors. Ezetimibe was the first agent introduced in this category. Selective cholesterol absorption inhibitors are often combined with statins in a pill form to give the patient their best chance of lowering LDL cholesterol and raising their HDL cholesterol. Fibric acid derivatives, also known as fibrates. Gemfibrozil and fenofibrate are the preferred drugs among this category because they are more effective and have fewer adverse effects than some other drugs. They are both highly effective at lowering triglyceride levels and increasing HDL, but they do not have a good effect on lowering the LDL level. Bile acid sequestrants, such as cholestyramine, cholestyramine, will increase excretion of cholesterol and reduce LDL levels. They can do this by forming a solid compound with bile salts. This increases bile loss through feces. Bile acid sequestrants will reduce the absorption of fat-soluble vitamins, vitamins A, D, E, and K. The patient can show symptoms of vitamin deficiency, especially when taking these drugs in high doses or for a long time. Niacin or nicotinic acid. The main problem with the use of niacin is the expected side effect of flushing. No cholesterol-reducing drug will cure hyperlipidemia. For patients taking non-statin anti-hyperlipidemic drugs that affect the absorption of cholesterol from the GI tract, you will typically give supplemental doses of vitamins A, D, and K. As for statins, you should carefully review for the proper timing of these medications in relation to meals. For best results, fibric acid derivatives such as gemfibrozil should be given within 30 minutes before the morning and evening meals. The healthcare provider will order follow-up tests to determine the patient's responses to cholesterol-lowering therapy. Teach your patient and family the following. You should take the drug at the prescribed time every day because it is important for the cholesterol-lowering drugs. Notify your healthcare provider and your pharmacist that you are now taking this drug so that they can carefully review any drug interactions with any other drugs that you are taking. If you have any significant side effects, notify your healthcare provider before you consider stopping the drug. These drugs will not by themselves cure high cholesterol. You must continue to make healthy lifestyle choices. Managing hypertension will dramatically reduce the odds of a patient's risk of heart attack, stroke, or kidney failure. Whatever the cause is, whenever high blood pressure is treated or poorly treated, serious health problems can develop when it is untreated. Accurate diagnosis is essential to determine the best treatment for patients. If lifestyle changes alone are not effective in reducing the patient's blood pressure, healthcare providers will begin drug therapy. An antihypertensive is a drug that has the main purpose of lowering blood pressure. A variety of drugs can lower blood pressure through different mechanisms. Drug therapy for high blood pressure will often require trial periods to establish the right drug or drug combinations to help a patient achieve their blood pressure goal. For the general population, non-African American patients should typically begin with thiazide diuretics. For African American patients, thiazide diuretics and calcium channel blockers should be used for the best management. Additional classes of drugs commonly used in the management of high blood pressure include beta blockers, alpha 2 agonists, combined alpha and beta blockers, and vasodilators. Although the antihypertensive drugs have different actions, some of the nursing implications are the same for all of them. Patients may need several types of drugs to achieve the best management of their blood pressure. Antihypertensive drugs can be grouped into 5 main categories. 1. Diuretics. 2. Renin-angiotensin-aldosterone system or RAS drugs. 3. Calcium channel blockers. 4. Adrenergic agonists or adrenergic agents. These would include beta blockers, which are non-selective and selective, alpha antagonists, alpha agonists, and combined alpha and beta antagonists. And 5. Vasodilators. Renin-angiotensin-aldosterone system or RAS drugs include ACEs and ARBs. These interfere with the actions of angiotensin II and aldosterone to decrease blood pressure by decreasing vasoconstriction and fluid volume. When a person's blood pressure drops, the cells in the kidney will release a hormone called renin into the blood. The renin will then produce angiotensin I. Angiotensin I is converted to angiotensin II by an enzyme called the angiotensin converting enzyme, or ACE. Angiotensin II is a hormone that causes vasoconstriction and will stimulate the adrenal cortex to increase aldosterone secretion. Aldosterone then increases water and sodium reabsorption. A good grasp of this process can be helpful in understanding how ACEs and ARBs work to reduce high blood pressure. An angiotensin converting enzyme inhibitor, or ACE inhibitor, is a type of RAS drug that reduces high blood pressure by stopping the conversion of angiotensin I to angiotensin II. An angiotensin II receptor blocker is a type of RAS drug that will block the vasoconstrictor and aldosterone secreting effects of angiotensin II. It can lower blood pressure by selectively blocking the binding of angiotensin II at the receptor sites found in many tissues. Calcium channel blockers are a class of antihypertensive drugs that lower blood pressure by reducing the effect of calcium in the heart muscle and the smooth muscles of arteries. Calcium channel blockers will help slow the flow of calcium ions across the cell membranes. This reduces the amount of calcium available for arterial smooth muscle contraction and produces a relaxation of coronary and systemic arteries. Some calcium channel blockers can slow the flow of electricity through the cardiac conduction system. This slows the heart rate and can be used to treat abnormal heart rhythms. Adrenergics are a category of drugs that affect nervous system control of various organs and tissues. They do so by activating or blocking receptors that will respond to the body's natural adrenergic substances, including epinephrine and norepinephrine. There are two main types of adrenergic receptors, alpha and beta receptors. Drugs that stimulate these receptors are known as agonists. They will turn on that response. Drugs that block the receptors are known as blockers or antagonists. They prevent an expected response. Beta blockers. There are two main types of beta receptors, beta 1 receptors, located primarily in the heart, and beta 2 receptors, located primarily in the lungs. A beta blocker is an antagonist drug that blocks the activity of beta adrenergic receptors. These drugs can be classified into two groups, non-selective and selective beta antagonists. Blocking beta 1 receptors will decrease heart contractility and heart rate. On the other hand, blocking beta 2 adrenergic receptors can cause bronchoconstriction. This can be a problem, especially in patients with asthma. Names of beta blockers will typically end with the suffix OLOL. Examples include metoprolol, propanolol, and sotalol. Alpha-1 adrenergic antagonists. Stimulation of alpha-1 adrenergic receptors will cause arterial vascular smooth muscle constriction. An alpha-1 adrenergic antagonist is a drug that lowers blood pressure by blocking the adrenergic receptor sites in blood vessel smooth muscle, and when activated, they will cause vasoconstriction and raise blood pressure. The alpha-2 adrenergic agonists work centrally in the brain, turning on special alpha-2 adrenergic receptors that, when normally activated, will cause vasodilation and decrease blood pressure. These drugs can be very helpful in reducing blood pressure, but do have significant side effects, so they need to be used very carefully with regular blood pressure monitoring. Combination alpha-beta blockers will have the benefit of affecting the responses of both types of adrenergic receptors. Vasodilators are a class of drugs that dilate blood vessels in several ways. Dilation of the blood vessels will decrease blood pressure, improve blood flow to major organs, and decrease the workload on the heart. Antihypertensives and diuretics can be used alone or in combination to decrease elevated blood pressure to a desired level according to our accepted guidelines. All blood pressure drugs can cause hypotension. This is blood pressure that is too low to maintain adequate circulation. Most of them can cause orthostatic hypotension, dizziness that occurs when changing positions. Symptoms associated with blood pressure that is too low include dizziness, weakness, and confusion. These symptoms can lead to an increased risk of falling. When the blood pressure drops below 90/60 or the patient is experiencing severe side effects, you must notify the healthcare provider to determine whether an alternative drug could work with fewer side effects. All antihypertensive drugs can have drug interactions, so you must check each drug that the patient is taking. Any interactive effects could lower blood pressure too much, or it could make the blood pressure go even higher than normal. In assessing your patient with high blood pressure, remember to consider all modifiable and non-modifiable risk factors. Lifestyle changes will be critical, whether the patient is taking drugs for high blood pressure or has elevated blood pressure. Before giving any drug that affects blood pressure, you must assess baseline blood pressure and heart rate. If the heart rate is lower than 60 beats per minute, withhold the drug and contact the healthcare provider. High blood pressure has no cure, but it can be well managed. It's important to involve your patient in planning this care as much as possible so that they will better understand why taking this drug is important. Compare their current blood pressure with baseline values and ask them about any side effects that the new medication could be producing. Teach your patient and family the following. Take the drug exactly as ordered. If a dose is missed, it must be taken as soon as you remember. If the next scheduled dose is too close, you should skip your missed dose and return to your regular dosing schedule. Teach the patient proper techniques to monitor their blood pressure at home and their heart rate. If the blood pressure is lower than 90/60 or the heart rate is less than 60, do not take your medication and contact the healthcare provider. Keep a daily record of your blood pressure to bring in to doctor's appointments. Remember to get up slowly from a lying or sitting position. Notify your healthcare provider of any new or uncomfortable symptoms that develop. Avoid alcoholic beverages when taking drugs for high blood pressure. And keep with you a list of all the drugs that you take so that healthcare providers will be aware of all doses and types of drugs that you are using. Major classes of drugs to treat or manage angina are known as nitrates, beta blockers, and calcium channel drugs. Calcium channel blockers. These are known as antianginals. Nitrates are a class of drugs that dilate blood vessels by relaxing vascular smooth muscle in the peripheral venous system and reducing resistance to blood flow in the arterial system. Relaxing the smooth muscle in the veins will help increase pooling of venous blood. This will decrease the amount of blood returned to the heart, known as your preload. Relaxing the arterial system will decrease pressures in the heart used to pump that the heart has to pump against. This is known as afterload. Rapid-acting nitrates, such as sublingual nitroglycerin and intravenous nitroglycerin, will be used to relieve pain in acute angina. Nitrates will reduce the work of the heart after an MI or in patients with heart failure. Throbbing headaches caused by rapid blood vessel dilation in the head or face will occur in more than 50% of patients who take nitrates. These headaches generally occur very quickly after taking the drug and will usually go away if the patient is taking low doses. It is common for patients to experience a slight drop in their blood pressure after taking the drug due to the venous dilation. Severe postural hypotension, reflex tachycardia, or paradoxal bradycardia, vertigo, and severe weakness can occur as adverse side effects. Alcohol, antihypertensive drugs, opioids, and diuretics can increase the effect of nitrate drugs, leading to tachycardia and severe hypotension. It is important to get a baseline assessment of heart rate and blood pressure before giving any nitrate drugs. For patients with acute angina, you must get a good description of their symptoms, including the onset, duration, and characteristics of pain. Ask patients if they have ever felt a pain like this before, and if so, what did they do to relieve that pain? You must perform a thorough pain assessment. An advantage of nitroglycerin and other nitrates is that they can come in a variety of forms. Nitroglycerin tablets will be easily absorbed under the tongue, and they are recommended in an emergency situation for quick action. Nitroglycerin is also available as a paste or a transdermal patch. This will allow the nitroglycerin to be absorbed into the bloodstream through the skin. You can carefully titrate intravenous nitroglycerin to relieve pain in severe angina. Remind the patient that sublingual nitroglycerin should be absorbed under the tongue, and it should not be chewed or swallowed. This will affect the absorption of the drug. Remove all old nitroglycerin paste prior to applying any new paste. This is to prevent dosage accumulation. Always wear gloves when applying nitroglycerin paste because it is absorbed through the skin on patients and on nurses. On page 156, see the purple box with top tips for safety. Teach patients not to chew or swallow their sublingual nitroglycerin tablet because the drug will be destroyed in the GI system and it will not help the angina. Almost all patients taking nitroglycerin will experience a drop in their blood pressure because it is a strong vasodilator. Do not give nitroglycerin if the patient's blood pressure is lower than 90/60. Patients will typically experience a sudden headache after taking nitroglycerin. You can administer acetaminophen or another pain reliever that will help reduce their headache. Patients can develop a tolerance to nitroglycerin, and they must have time off of the drug so that it will not lose its effectiveness. For example, a nitroglycerin patch can be placed in the morning, and then it must be removed at bedtime as directed. If the patch were not removed and left on the body for 24 hours, the next dose will be less effective, and the patient will not receive the benefit of the nitrate. Sublingual nitroglycerin is given to patients with sudden onset of angina. It is fast and it can be very effective. For evaluation, you must ask whether the nitroglycerin relieves or reduces their angina, and if it does not, call 911. Evaluate your patient's blood pressure carefully after giving any nitrates until you are sure about the patient's usual response. For sublingual nitroglycerin, you must monitor blood pressure every 5 minutes until pain is relieved or until emergency care providers have arrived to transport the patient to an acute care setting. Teach your patient and family the following. Keep nitroglycerin tablets in a dark glass container to prevent the breakdown of the drug. You should always store it in the original container. Do not transfer the tablets to another one. Carefully check the expiration dates. Tablets that have expired are not effective for treating chest pain. Do not drink alcoholic beverages while taking any nitrate products. If you're using a nitroglycerin spray, do not smoke or use the spray near an open flame because this drug is flammable. For transdermal patch application, select a hairless spot and apply the patch to the skin. Do not cut the patch because it will affect the dosage of the drug. Avoid drugs for erectile dysfunction, such as Viagra, because they can cause a severe drop in blood pressure. Keep a record of every angina attack. Antidysrhythmics. If there are threats to functioning of the pacemaker of the heart, the patient can experience an abnormal rhythm and cardiac output will be reduced. The abnormal rhythm, whether too slow or too fast, can have a significant impact on cardiac output. These abnormal rhythms can be benign or they can be life-threatening. We use the term dysrhythmia rather than arrhythmia to describe an abnormal heart rhythm. Common causes of dysrhythmias include hypoxia, fluid and electrolyte imbalances, adverse effects of certain drugs, and interventions for the heart. The primary nursing issue is whether this rhythm affects how well the patient's heart can pump. An antidysrhythmic drug will work to make the heart rhythm more regular and reduces serious dysrhythmias. These drugs play an important role in treating abnormal heart rhythms to help the heart achieve a more normal rhythm. Antidysrhythmic drugs can affect the cells that are beating irregularly during different phases of electrical conduction. Antidysrhythmic drugs are classified using the Vaughan-Williams classification scale. It organizes the drugs according to where they act in the conduction cycle. The cause of the dysrhythmia will determine which drug class will be most effective for treatment. Digoxin can be used primarily to treat heart failure, but it can also play a role in treating fast dysrhythmias, such as AFib or SVT. Toxic levels of digoxin can also lead to dysrhythmias. As the patient's condition becomes more stable, oral versions of the antidysrhythmic drug or another antidysrhythmic can be used for long-term therapy. On page 159, see the orange memory jogger box. Learning common suffixes can help you recognize the specific class of drugs. Beta blockers will often end with OLOL. ACE inhibitors will often end with PRIL, and ARBs will typically end with sartan. This is a good mnemonic to remember to easily identify your drugs. Drugs that are given to control dysrhythmias can cause other dysrhythmias. It is best practice to assess the apical heart rate using your stethoscope prior to giving the drug. Some irregular heart rates will be too weak and difficult to palpate using a radial pulse alone. The healthcare provider will typically obtain an EKG before giving the drug. You should take baseline and follow-up vital signs whenever giving antidysrhythmic drugs. Hospitalized patients will often continue their antidysrhythmic drugs when they go home, and you should take advantage of every opportunity to teach the patient about these drugs. In some settings, the patient will be monitored using telemetry. Monitor for changes in vital signs because improvement in rhythm will often lead to improvement in the vital signs. Teach your patient and family the following. Take the drug exactly as ordered and do not skip doses or double the dose. Report any new or distressing symptoms to the nurse or healthcare provider, especially sudden weight gain, trouble breathing, or increased coughing. Return regularly for checkup visits to see how the drug is affecting your heart function. Do not take any other drugs before consulting with your healthcare provider. This includes aspirin, laxatives, cold and sinus products, and other over-the-counter drugs. The term inotrope is used to describe the contractility of the heart. An inotropic drug will affect the contractility of the myocardium. In heart failure, positive inotropic drugs can increase contractility and therefore increase the ability of the heart to pump blood. Examples of positive inotropes include cardiac glycosides, including digoxin, phosphodiesterase inhibitors, such as milrinone and dobutamine. The major cardiac glycoside is digoxin. As a positive inotrope, digoxin will activate the contractile proteins in heart muscle. This increases their ability to contract. In patients with heart failure, an increased force of contraction can lead to an improvement in cardiac output. Digoxin affects the conduction system of the heart, decreasing the heart rate. As a result, digoxin can effectively treat AFib in some cases. Positive inotropic drugs are primarily used for symptom management in patients with advanced heart failure and in critical care areas to increase the contractility of heart muscle and improve cardiac output. Symptoms of digoxin toxicity include anorexia, nausea, vomiting, diarrhea, visual disturbances such as blurred or yellow vision, and an irregular heart rate. A blood test can tell you the level of digoxin. This is known as a DIG level. It is a tool that can determine the correct dose and protect the patient from toxicity. Treatment of digoxin toxicity would begin by stopping the drug and treating the associated symptoms as needed. Beta-adrenergic blocking agents, calcium gluconate, calcium chloride, succinylcholine, and verapamil can all increase the therapeutic and toxic effects of inotropic drugs. You should always take vital signs before giving digoxin or any inotropic agent. If you have a patient in an acute care setting who is taking digoxin for AFib, it is also important to have a skilled monitor technician available to monitor any changes in the EKG. You must also assess whether the patient's potassium level is within normal limits, because a low potassium level can increase the risk of digoxin toxicity. If you're caring for a patient who is receiving intravenous milrinone or dobutamine, carefully monitor for a rapid heart rate and negative changes in the patient's condition that can indicate adverse effects. Know about two types of doses for patients taking digoxin. This is the initial loading dose and then the maintenance or regular daily dose. The healthcare provider might prescribe a higher and/or a more frequent dose when the patient first begins taking digoxin. This is in order to reach a target blood level for a specific response. Then, when that target blood level is reached, a smaller dose can be given once daily to maintain that blood level. Monitoring for drug toxicity is important for any patient taking a positive inotropic drug. The therapeutic level of digoxin is 0.5 to 2 nanograms per milliliter. If the level is 2 or above, you must hold the drug and notify the healthcare provider immediately. Teach your patient and family the following. Let your healthcare provider know if you have any loss of appetite, nausea, vomiting, diarrhea, or vision changes. These can be an indication of digoxin toxicity. Do not skip a dose or stop taking the drug without discussing this with your healthcare provider. Keep appointments with your healthcare provider to make sure the drug is still effective. Do not take any other prescription or over-the-counter drugs without prior approval from your healthcare provider. Notify your healthcare provider of any chest pain, shortness of breath, or peripheral edema. This could indicate worsening heart failure. You must include foods rich in potassium within your diet. Good sources of potassium includes bananas, orange juice, green leafy vegetables, and baked potatoes. We can also see foods that are high and low in potassium on page 138 within box 9.1. Foods with high or very high potassium levels.